and we try in my provisional. And this part is so important because if I put that provisional in and the occlusion is correct and the contacts are correct, that tells me that every step up to then was right. I got the transfer pin all the way in. I got the model poured up right with the analog. I got everything right. It's not going to come back from the lab looking great on the model. Then you put it in the patient's mouth, and the margin is 3 millimeters off. So right there, I checked this out. It's fine. Okay. Then I took my impression, just like a regular crown and bridge impression. Okay, the laboratory gets this just like they would get an impression of a prep natural tooth. So there's no trepidation on their end. They're not going to have to worry about, is this right or is this wrong? Do I have the components integrated correctly? Do I have them seated on the model correctly? All these things where errors can occur have been eliminated because they're getting an impression that's just like a crown and bridge impression. And my philosophy on implant restoration is this: get it as close to regular crown and bridge as you can. Get it as close to regular crown and bridge as you can. Now, 3 weeks later, this comes back, and we're starting to get a little bit more papillary invasion here, you might say. Remember what it looked like. So we're getting some tissue maturation there. I didn't realize this. I didn't realize what was going on there. And so this is the final result that I got. Okay? Better tissue contours than you saw in that soft tissue model, but not as good as they could have been. What is the mistake that I made here? I made a mistake here. What's the mistake?
You didn't use ankylose.
Number one. No, she's correct. Number one. Number two, what's another mistake I made here?
I think I would have flared the gingiva a little bit more, so that,
Waiting.
Mm-hmm.
Waiting. Have the provisional in there longer, and that tissue will fill out
grown, yeah.
as long as your contacts aren't too far away from the crestal bone. Okay? They will fill in. If you're more than, I think Tarno says, 5 millimeters from the crestal bone, then all of a sudden your chances go down. But if you've got them there 5 millimeters or shorter, it'll fill in if you give it the time, if you wait, if you have the patience. And explain that to the patient.
Waiting with the provisional?
With the provisional.
Why won't that continue with the final? What's the...
It may or it may not. And my point is that patients judge it from day one. Okay? Now, if this were an anterior and you put that in and there's the final, you say, oh, don't worry, give it a few more months and we'll be okay. You're going to get a lot of skeptical looks.
yeah.
There's going to be a lot of people who and I want this from day one to be right. And I'll show you how we get there. Because patients don't have the confidence in your knowledge the way you have it in your own knowledge.
No.
You know that, yes.
Having been a general practitioner for 10 years before becoming an endodontist,
Mm-hmm.
when you do good temporaries and you tell the patient, let's wait 2 or 3 months to see if the papilla grows. When I did crown and bridge, I had many patients that they never came back for the final.
Mm-hmm.
They said, this temporary looks great, why am I going to pay for the final?
Luckily, I really haven't had that problem, but I've heard of this before.
Mm-hmm.
And it's really important at the diagnosis appointment to discuss things like that.
Mm-hmm.
We're going to do this, we're going to wait this long, you're going to think this looks great, but let me tell you, it's not going to last you. Okay? Yeah, that's again laying the groundwork. And I haven't really had that problem, and that's probably because I spend so much time on it to begin with, but I've heard of other people. You're not the first one who's told me that. Yeah. Boy, that's a bummer, isn't it? That really is a bummer.